Good morning, everyone. Great to see you all. Welcome to day 2 of the APSF Stoelting conference. And I wanted to thank you all for being here, and also just let you all know that before we get started with our last session, after the session, we'll have a 15-minute break, and then we'll ask all of you to get into the breakout sessions, which will be right here in this room. We have 5 breakout sessions, and so just based on the topic, self-select and then go to that session. So we're gonna have session 1 there, over there, and then session 2 to the back where Dr. Warner is, session 3 in the front right here, session 4 over there, and then session 5 in the back on the left side. So, and then these are the session leads that will be leading the discussion and scribing. And then from this breakout session, we'll gather again here. So the breakout sessions will go from 9 to 10. And then at 10 o'clock, we'll gather back in this room, and our session leads will report back on some preliminary recommendations, and then we'll adjourn at 11 o'clock today. And so without further ado, we're going to get started with our first session.
Is it Ken again?
Yes, it's that intro slide.
Okay, awesome. It's always Ken.
It's always sorry. Thank you.
Is this somebody's phone?
That's not mine.
Okay.
It's mine.
Oh, okay.
I was going to set a timer so I stay on time.
Okay. Good morning, everyone. Welcome to this first session of today. This session is a sister session to last night's session, and we're looking at technology that can be directed at opioid harm. And we have some great speakers lined up to tell us a little bit about that. We've got G. Mathen, Laura Lobaugh, Carollo, Amanda Hayes, and Sesh Mudumbai. And we're grateful for them to come here and tell us a little bit about that. Just a quick reminder, it's 12 minutes each, and I'll be a little friendly reminder as we go along. And we'll look forward to an exciting hour. We're going to start off with G. Welcome. Come on up. Oh, okay.
Yeah. How do I just this?
Oh, yeah.
And I can just push this.
Yeah. Give it a go.
Good morning. I am Lauren Lobaugh, and I am the Director of Safety for Anesthesia Services at Texas Children's. And this is my partner, G. Mathen, from the pharmacy at Texas Children's. We have nothing to disclose. Arnie? Shouldn't the thing have popped up?
We literally just saw it.
I know.
Oh, you opened the wrong one.
Oh.
That happens.
Small technical difficulty. So the first breakout question for this morning we're going to warm up with is, describe the relationship between anesthesia and pharmacy at your hospital. I think I have to go to get the class. So that's much more positive than I thought it was going to be. But there's some words that resonate, I think, across many relationships that can be siloed or strained, fair. But G and I
are talking about our story today and our partnership. So in 2021, G and I were on the ISMP Peri-Op Guidelines roundtable, and it was virtual because it was 2021. And I remember being in this roundtable, and we're all talking about our individual practices and what we do. And there was this discussion about technology and Epic. And G offered up some comment at Texas Children's, and I sat there and I was like, I don't know where he works because I work there and that does not happen. And so that was 2021, and we moved on, and I didn't know G and G didn't know me at the time. I was a relatively new attending at Texas Children's. And then we fast forward about a year ago, and we had an RCA. From an event with a medication error. And it was around ketamine. There was a ketamine shortage at the time. And so our normal process wasn't going to work. So we had to go through pharmacy for a ketamine preparation. And there was an error because people were doing unfamiliar work patterns to work around the solution. And one of the things that came up in the RCA over and over, which is consistent across all RCAs probably, is communication. Communication was the biggest breakdown. And G and his pharmacy team offered up their recommendations in the RCA, and I had mine. And it was work as imagined and work as done. So on the pharmacy side, G and his team think something happens in the OR because that's what the books say or that's what the guidelines say. And then I offer up this nice, lively comment of, that never happens. I don't know where you are. And so what we realized was that we had an opportunity to form a relationship. As Dr. Eckhorn said yesterday, you have a problem, you form a committee. So we formed a committee that is called the Perioperative Medication Stewardship Committee at TCH. And like was highlighted by some of our other colleagues in the room, you got to have the stakeholders. So G and I are the co-chairs of that committee, but along that committee, there's nursing leadership, PACU leadership, there's a couple surgeons because we need their input from time to time, but it's predominantly anesthesiologists across our 4 campuses and the pharmacy leadership across those 4 campuses. Because at Texas Children's, we have an even bigger challenge of we have now 4 hospitals spanning the state. We do 60,000 cases a year. And G has a very big task of trying to make 120 anesthesiologists happy. So in this committee, we realized that we can really optimize our workflow. We can make the processes better, but we also realized that G has a lot of data and information that as an anesthesiologist, I don't have access to. I live my day in the clinical environment. It's a very heavy clinical load, but through partnering with G, I'm able to get information that would take me months if I put in a front door ticket in Epic. And so we really are leaning into that partnership and collaboration to try to optimize our environment and make things better.
Thank you, Dr. Lobaugh. So the partnership is very important for us. In pharmacy, for many years, we've been a very data-driven department. And see from this slide, we have access to almost every piece of data that comes into the system, from automated dispensing cabinets to the EHR, to the parking system, to transport, anything that comes to it, we get it, put it into the EDW, and we've been able to run dashboards off of it. These dashboards have helped us move forward in pharmacy. And so one of the things I heard yesterday was a conversation related to how are we going to use technology in the future. So in order for us to move forward in pharmacy, we took a lot of time studying the airline industry, like everybody mentioned before. One of the things that we learned out of the airline industry that was important was how do you take this data and do it for the good? So airline industry, high reliability, high safety, and reduction of cost, right? So Airbus, a leading airplane manufacturer, decided they were going to take a look at what they could do to improve something. So what they did was they looked at all the options, pulled the data, and they figured out tires were an option to look at. So you think tires. Well, tire on an airplane costs about $15,000. You get 40 cycles with it. That means 40 takeoffs and landings, but they were only averaging 20, 25. When they started doing the study, they realized what happened is that each pilot has variability. So each pilot would step on the brake when landing and wear the tread down differently. So they said, hey, if we can get standardization, we can get these tires to last longer. So they built in AI that actually calculates, presses the brake, and lands it exactly where it needs to be. Why is that important at this meeting? I honestly think that that's the type of information that we can take from anesthesiologist workflow that's documented in multiple systems to try to figure out an auto braking system. How do we standardize IV syringes? How do we make sure what individual thing would make it easier for the provider to focus on what's important, right? Drawing up accurate syringes, right? Using technology to give pre-filled syringes. We can do that, but we need to know which ones to attack first, because you can't put everything as pre-filled syringes. So we started about going to dashboards. First thing we looked at is discrepancies. And these discrepancies helped us try to say, how do we level set with Dr. Lobaugh? And so we pulled information in, we looked at it back and forth, and it helped reduce the number of discrepancies. If you have a discrepancy, you have to go back and have to answer for it. So these discrepancies, if we have a dashboard that provides you this information, and we're working on actually putting it on your phone. So you as an anesthesiologist can walk in and look and see if you have a discrepancy before and at the end of your case and solve it. So you're not being chased by pharmacy quality person or pharmacy data person over the auditing of narcotics. So that's one thing we're working on. We're looking at different types of anesthesia dashboards. We're looking at where we have population geotagging. We're looking at usage in different ORs. We're looking at total waste. We're looking at doses that were scanned but not administered. Things that we thought were impossible, for at least from the anesthesia perspective, when we talked to Dr. Lobaugh, are becoming possibility. But what it takes is the partnership. That partnership between the subject matter expert, the data provider, and the provider of the medications. And I think we have a long way to go, but I think data is going to help us drive our decisions in the future. You know, everybody's heard "in God we trust" and everybody else must bring the data. That's the way we should be looking at anesthesia.
So the other thing that G has done for our group is technology. So anesthesia, I think it can be challenging to ask for technology implementation in the OR, and a lot of times you're told, well, that costs too much. I lean on G because G has money that I don't have. And so at TCH, we've been able to use things because he can see opportunity in utilizing that technology that helps on the pharmacy end, and he can have a selling point from that advantage. So at Texas Children's, we do use automated dispensing cabinets that I think provide a great opportunity to have access to the meds that we need. We tailor them for those cases that are done in that room or that environment. Right now, we are trialing the Wave scanner at Texas Children's, which is an interesting addition because, as many have said, anesthesiologists are very resistant to change. They live in their own environment. And what I do every day, I don't want to be disrupted by something that is time limiting. However, sometimes you have to eat broccoli and asparagus, even if you don't like them. And so what I have shared with my group is I can't go to a leadership meeting again and say, well, we'll work on re-educating that provider based on that error. It's a horse that is beaten to death over and over and over again. So we really feel like you have to make the room smarter. I can't get any smarter. I truly can't. And so if the room is smarter, it can allow you the opportunity to provide great care that has a safety net. Because as many of you have said and highlighted, at Texas Children's, 70% of our attendings are by themselves in the room. There's no safety check. So how do you build in a safety check? Scanning that med, having audible readouts of that med, alerting you to allergies can do that. The other thing which some people have, but I think is something that we need to strongly encourage, is not only pre-filled syringes, but those can be expensive. It's making syringes that tailor to your environment. So at Texas Children's, my ask, which G has promised by the end of the year, is robotically made meds. Using meds that are wasteful, like in a pediatric environment, dexmedetomidine comes in a big vial. I may use 3 cc's out of that entire vial and waste it. That's hard on my, green, crunchy Birkenstock wearing heart sometimes. And so I think that by having a robot and tailoring those, it provides a safety layer, because the resident doesn't grab the whole vial and think, oh, I'll just give the whole thing, or the attendings can make the mistakes also, but really leaning on partnerships with pharmacy to bring that technology in to make the environment that you work in safer.
So as Dr. Lobaugh says, partnership. Our partnership looks at our current systems, electronic health records, opioid risk assessments, prescription monitoring, clinical decision support, all of this that ties into patient safety. The future is going to be smart packaging, mobile apps, drug diversion prevention, staff education, continuous evaluation, but it all starts with data, and data is going to be key. So we're looking forward to the evolution of where we go with anesthesia. I'm really excited that we can solve some problems. And sometimes it's not just the solution. Sometimes it's just understanding, do we have a problem? And using data to look at repetitious patterns that help us understand where we're going. Thank you.
Just look right here.
All right, thank you all for the opportunity to present a topic that I'm passionate about. I've been a pharmacist for almost 25 years at this point. And early on in my career, unfortunately, I learned about drug diversion by the fact that I was working with a colleague who unfortunately had some home life stressors. And then as time went on, I realized that she had just not been around at work. Unfortunately, she had been borrowing some of the medications from the pharmacy's controlled substance safe, and she, was gone for a while. When she came back to work, fortunately, she was able to, maintain her license, come back to work without access to controlled substances for quite a long period of time. The environment that she came back to work in was obviously a lot different. And so early in my career, I had that experience. And then I would say over the last 25 years, I've had the opportunity to sit in front of people that we're talking with about drug diversion prevention, talk with people who are actually being investigated. And each time at the end of it, I see an individual who's suffering, who we heard a lot about burnout yesterday. I've seen clinicians just roll up their sleeves and say, thank you, I have a problem. Having track marks, I've seen clinicians, unfortunately, we've all seen the stories. And so since I've switched from clinical practice to the vendor side, I'm now in medical affairs with BD. I'm excited to be able to talk today with one of my great partners, Dom Carollo, about our partnership as it relates to drug diversion prevention in his hospital system. But this is something that I'm passionate about. And I'm excited to say that that pharmacist that I was talking about earlier has been in sobriety now for 25 years. She is in, great in recovery. And now she's my sister-in-law. So I didn't know, I ended up meeting him a couple of years later. So I've been alongside a family member in recovery. I'm sure many of you likewise have people in recovery. And so for me, this is not about catching the diverters. And you may say as a pharmacist, that's odd because your job is to be the police of the narcotics, right? But for me, it's personal. And so I come at it with that passion and belief in recovery. And so we need to help detect things sooner rather than later. So today we're going to talk a little bit about the problem of drug diversion and the challenges associated with it. But we're also going to talk about how technology has evolved. I started back in pharmacy practice in the 90s. So paper orders and all of those wonderful things that were so challenging to be able to triangulate where you might have challenges. We'll talk a little bit about that. We'll talk about the role of an IT partnership, really focusing on that vendor to clinician partnership, and then share kind of what a vision for the future may look like. So the current state, maybe just show of hands. How many of you have worked alongside a colleague or peer that has struggled with substance use disorder? Almost every hand went up for those of you who are virtual. Leadership really, a couple of years ago, BD did a study to look at how many people really thought that there was a problem with drug diversion prevention in their hospital. And everyone said, yes, I understand that that's a problem, but it's not going to happen to me. Not in my hospital, not in my health system. And over the last several years, we've really seen a shift in that. Unfortunately, pharmacies and health systems have seen massive fines related to DEA investigations due to drug diversion cases. And so there has been a little bit of a shift. And with that, there's also been some new guidelines that have been developed. And then the role of technology has really dramatically changed over the last 10 years as it relates to how you can go about looking at these things and hopefully detecting it sooner so that you can get that clinician help. The headlines are not favorable, particularly around anesthesiology and the practice of anesthesia. And these are just 4 examples. I've redacted the names, but at the end of the day, the stories are horrible. These often, when they happen, hit headline news. And nobody wants your organization or your close colleague to be in this situation where their name's in print, or further, that they might actually be deceased. The ripple effects that it has on healthcare, the team that's remaining when this kind of thing happens is really devastating. And so we want to prevent this type of thing from happening. And unfortunately, it's really not just about the clinician. And, obviously, we first and foremost want to get them the help they need, but it's about the patients. And drug diversion is a patient safety problem. And I have to applaud so many organizations coming out and really thinking of it in that lens versus just the compliance lens over the past few years. ISMP has been a strong advocate for this. American Society of Health System Pharmacists has as well. But really, at the end of the day, when you have a clinician who's impaired, there's a patient who's either not getting the medication that they need so that they could still be in pain. They're getting underdosed or maybe not dosed at all because it's been tampered and substituted. Or worse, how many of you saw the podcast about patients who were having egg retrieval without pain medications? If you listen to that podcast, it's just heartbreaking to think about the pain that those women were in going through those procedures. And then there's the latent things like hepatitis that may not be detected for years. And there's been many, many cases like that. And then other bacterial infections. And I won't go through all of those, but there's also an active case in the Pacific Northwest where there's essentially 16 related tampering deaths where water was substituted for fentanyl in an organization. And there's up to 44 investigations that are continuing to ongo in that case. So this is a real problem. As you constrain the system, you have a lot more of these tampering cases that can have even worse and more really devastating consequences for the patients. So the American Society of Health System Pharmacy has developed some guidelines over the past few years, 2 versions of those. The first of being in 2016. I had the opportunity to participate in the 2022 guidelines that were updated. And I would say it was an exciting time to really think about what had changed from 2016 to 2022 as we rewrote these guidelines. One of the things I would say is that, 2022, we were in COVID still, we were really kind of coming out of it, but we recognized that a lot of things needed to change about these guidelines from the first draft to where we were at that point. And so I think the key call outs are that, it used to be a pharmacy problem. They really called on anesthesia leadership and the important role of an anesthesia leader on your drug diversion prevention program. And then it needed to be more multidisciplinary in nature. They also highlight, obviously the areas that are of greatest risk, and no surprise to this audience that the controlled substance volumes in the procedural spaces remain high risk for potential diversion, and you need to have a little extra leadership and attention and processes there, including automation and technology, things like automated dispensing cabinets, as well as having surveillance programs. And surveillance programs can look at a couple different things. I know many people have gone down the path of implementing cameras in the operating room that can specifically look at where your controlled substances are moving, obviously protecting the patient's privacy still. That's one aspect. But then on top of it, we have the robustness of new drug diversion prevention surveillance systems. So just a little bit more about advanced analytic technology and drug diversion surveillance systems. So when I was a early pharmacist in the 2000s, I remember the nice reports that I would get that would tell me that, you know, this nurse or this physician or this pharmacist was an outlier versus their peers and a statistical deviation. And there were always so many reasons that that wasn't the right way to look at it. You know, maybe it's that that nurse for good reason was picking up extra shifts, or that you know, that was the pain nurse for the floor that did those types of things. And there were patient, you know, things that you would look at, obviously, but it was really difficult. You spent a lot of time looking at reports. You spent a lot of time trying to triangulate what you really needed to be spending your time on to make sure that you were helping that clinician. And now these advanced analytics really help you kind of triangulate people who really look different for things you can't see with the naked eye. These are often powered by artificial intelligence through machine learning algorithms that are really complicated. And I'm by no means an expert in any of that. But what I will say is that as a clinician, I was able to often see these types of things are maybe somebody that I need to look at a little closer. I don't think that most people rely on these as the perfect needle in the haystack to say that this person is diverting. I think most people are of the mindset that this helps me see where I need to spend my time and who I really do need to look at a little closer. And maybe let's have a conversation with that person sooner rather than later. But the types of transactions that these things include are like, you know, I dispensed a medication after the patient was discharged. That's interesting. Why? Maybe that's a conversation. Just maybe they chose the wrong patient, or maybe they really are doing something that just you need to take a closer look at. How long is it that you're from the time you remove a medication until you're wasting it? And then are you just not really good at documenting? Maybe we need to have a conversation about that again. And then what about things like I'm pulling out a vial and I'm always wasting the whole thing, which benign probably if you see it periodically, but if it becomes a pattern or trend, you might start to worry about potential for drug tampering. And then if you have a buddy system, we see that a lot in nursing where people may work together to consistently waste, and that is a recognized pattern of potential drug diversion. So with that, I'm actually going to turn it over to Dr. Carollo, who's going to talk about the experience at Ochsner.
Hey, y'all. Thanks for having me. Thank you, Dr. Rebello, and the rest of the committee for inviting us. So Ochsner is to say a large hospital system in the Gulf South is understating it. It's the #1 hospital system in the Gulf South. And saying that we do 46 hospitals and more than 370 health science centers, so many ORs I can't count. I asked my pharmacist, how many opiate and narcotic pulls were there in 2023? And the number was 3 million across the system. 3 million different dispensions across the entire system last year. All right, so here, this is not the most fun topic to talk about, but substance use disorder. We know that we represent, as anesthesiologists, 1 in 25 of the physicians across the country, but yet we represent about 1 in 9 of the physicians that are that have substance use disorder problems and are currently undergoing rehabilitation. Well, it's considered our #1 hazard for our profession. And we know that 1 in 8 of us will develop substance use disorder and 4 in 10 will relapse over the course of their career. And we know that if a resident were to get substance use disorder, 1 in 9 of them will die. In the last 4 years, I can tell you this, we've had 2 residents that we've had to help with substance use disorder, 1 from anesthesia drugs and then 1 from what I would say, quote unquote, party drugs that we've been able to find through some of our diligence. All right, so I started residency in 2007, and looking out at this crew, I might be the youngest resident here. No, I'm just kidding. We documented on paper. You know, looking at Dr. Phillips, I'm sure that she documented on paper a long time, but we've all converted over to the electronic medical record, and that happened during my residency. Currently, of course, at Ochsner, we use Epic. And by the way, I'm sure a lot of people are going to use Epic. I am currently the chairman of the EPIC subspecialty steering board for anesthesia. So if you have a lot of complaints about EPIC anesthesia, you can find me. My email is at the end, and I will try to help you out the best we can. But that was a huge transition that just happened even in my career. Storage, man, I miss the tackle boxes a little bit. Just go get the tackle box, you lock it in your cart. But we all know that the automated dispensing cabinets is safer, and and hopefully a lot of us have transitioned to that. And that has been a big change in our careers. Labeling systems. I sort of miss the labeling roles. I don't know what you guys did sometimes during a long case. We'd make artwork with them. You know, you'd wrap it around your arm. You make bracelets. But then obviously when Jacob would come by, we'd all have our marker, and you'd have to write down, oh, DSC, the date it expired 24 hours from now. And then as soon as Jacob left, you'd throw that marker away. But we know that the codonics and those automated labeling systems is much safer for our patients and much more reliable of a system. So waste detection, you know, we went from a system where during my paper record, my attending would come in, he or she would sign for attestation for emergence, for presence, for induction, and then they would sign the waste at the exact same time at the beginning of the case before I had given even most of the narcotics. That was just a signature on a piece of paper. Not saying that was a good, reliable system, but it's the truth of what it was. Now, of course, we have 2-witness authentication. For us particular, it's through Pyxis, but automatic dispensing cabinets, or some people can do it within EPIC. And then, of course, the surveillance software. So as a lot of my colleagues here were talking about with the dashboards, we have we have data that comes out of the automatic dispensing cabinets. We have data that comes out of EPIC. We have data coming from everywhere. And we have they would send an email to the pharmacist would send the email to a chairman, say, hey, this looks funny. Or one of our people would send an email to the chairman and say, hey, you need to look at this person. And then they would take a long time to be able to do those deep dives. All right. So today we're going to talk a little bit about that transition. All right. So Ochsner, different sites, different places. We got to go from Shreveport, Louisiana, which is a 6-hour drive down to New Orleans. And they still were using a manual system in Lafayette. And we're using automatic dispensive cabinets, of course. EPIC is ubiquitous everywhere. In 2019, we failed an audit, a DEA mimicking internal audit. And of course, a personal friend of mine was in charge of the audit. And then she recommended to my chairman as a favor to me to be the anesthesiologist that would be in charge of reconciling all the audit findings. And I always appreciate Angel for that. So the first thing that we did, and this was through collaboration with the pharmacy and a great pharmacy leader, is that they hired someone named Alex. Now, Alex already was working in pharmacy, but he became the system-wide drug diversion, I'm going to say czar, but drug diversion director for the entire system. So we have one person for pharmacy, and he has 4 or 5 reports underneath him that is really in charge of making sure we can be reproduced across the entire system within Ochsner. Once again, 46 different locations. We have an internal manual process at my hospital, and we wanted to be able to reproduce that across the other hospitals. But the problem is the 2 people that do that, I'm going to give you their names. Their names are Lisa and Sandy, can't be just replicated and spliced and put at these other hospitals. And they can't do the work of all 3 million of these pools either. So how do we do that? And so we realized that we need to develop the IT. So of course, once again, all stories happen, during COVID. But then once we were coming out of COVID, we had identified a partner, and this partner particularly was BD, but it could be any of the vendors that was really interested in developing this analytics software on the back end. And we had meetings every Friday. They were looking at our workflows, looking at my workflow, CRNA workflow, looking at resident workflows, and then also looking at on the back end, the actual the pharmacist workflows, what reports they were looking at, what spy tools that they were using. And we developed this software together. And then we just said, well, let's do it now. Let's implement it and see if it actually does anything. So this is the study that we published in 2024. We finished this research in 2022. And really, I'm not going to go through all the details of this. Feel free to read the paper. But long story short, it just reviewed, the software was designed to review all the OR transactions and to try to make it, and to also review all the dispensions from the automatic cabinets and to try to correlate them together to see which actual discrepancies were real and which were sort of false discrepancies. And then also, what were the weird sort of things that could lead to someone to be able to be diverting. So as you can imagine, we found a lot of charting anomalies, but the two that I want to point out most and two that we were not looking at before was the whole dose waste or return. We did not find that to be as common in our manual process, but as you can see, there were almost 27% of our total discrepancies were found to be this whole waste return post-implementation. So some report was finding that, and yet it wasn't getting back to the anesthesia team that this was actually happening. And then the other one I want to talk about is dispense after discharge or transfer. Our initial reports weren't finding that at all. And that's a very easy diversion technique. Oh, the patient went home, let me go pull some fentanyl from them. And this new software and this new analytic tool was finding that. Obviously, the analytics save time. We went from 3 days to do a review of a particular provider down to under an hour. And we can do those reviews, and then a pharmacist will do those reviews. That gentleman, Alex, will see the abnormalities, and then he will call the chairman or call me, and we'll do a secondary review of looking at their cases. And sometimes we've had to actually go through and do drug tests, random drug screens, to make sure or to be able to help. Because remember, as people said, as Amanda said, we're trying to help people and to save lives. All right. So the vision for the future. You know, obviously, we all have the two signature, however you all do it within Epic or within Pyxis. But what is in that syringe? Is it fentanyl? Is it that the right amount? When you actually squirt it into the terminal waste, is that the right drug that you're doing? Do you know that it's saline? Now, we know that there's technology out there that's trying to look at like mass spectroscopy to like say, oh, that's fentanyl. That actually is fentanyl. And it's really clunky. But the goal, help long-term, is that we will have this technology that will really be able to use to know what's in that syringe and know what volume is in that syringe. But none of that is ever going to overcome us being a culture of safety. We had very big tragedy a couple weeks ago. We had an anesthesiologist pass away from overdose, and he had 0 Pyxis pulls, 0 wastes. Never, he was doing a direction practice. He's a regional anesthesiologist. Well, he was reaching into the waste bins and taking out the old 2 ml vials, and he had 50 of them in his hotel room when he died. And obviously, in hindsight, the cameras did catch him, but not beforehand. It's because no one was looking at that because he had no warning signs. None at all. None that I personally can see. And when you ask the people that knew him the best. So the technology is never going to get us all the way there because diverters are going to divert. But I want to be really clear is that we can work together and we can be vigilant for our colleagues and our friends. So those type of things do not have to happen. But no technology is ever going to be better than us being vigilant. All right. Thank you all very much for inviting me.
Great. Good morning, everyone. I'm really excited to be here, and thank you to the APSF for giving me the opportunity to talk. I'm at Stanford University. I'm also at the VA Palo Alto, so I hope to give you a little bit of a VA perspective. My contact information is below, so if you need to contact me, please use that. Like I said, I'm very excited to talk a little bit about augmented intelligence. Augmented intelligence is about using AI tools to help clinicians. And really, with the advent of AI and increasing use of AI within medicine, is how can we start to use these tools to help clinician decision making? This is all the more important, given the context of the opioid crisis. As we all know, there's a big human cost for the opioid crisis. As we heard yesterday, there's also a big economic and healthcare costs with ER admissions, with prolonged care of stay, and obviously adverse outcomes. I hope to talk to you a little bit about the current state of the opioid epidemic, a little bit about what I see are some of the gaps related to opioid risk management and potential and what augmented intelligence is and what it could be, and ways that and again looking more to the future as to how augmented intelligence, or how we should be thinking about augmented intelligence, can help manage opioid risks. I have no conflicts of interest that could affect the content of my presentation. My views here are not necessarily those of the Veterans Health Administration. Here are my sources of funding. I'd like you to take away three key takeaways. Certainly, what are some of the potential gaps in opioid risk management? What is augmented intelligence, and what are the ways that augmented intelligence could help in managing opioid risk harms? The first, in terms of the gaps, are really a lack of comprehensive risk assessment tools that can incorporate all of the data streams that we are currently having and that we will have. Things such as certainly the EHR, but information from public health sources, from genomic data, metabolomic data, immunologic data, microbiomic data, wearables. How can all of those data streams be incorporated to provide a comprehensive picture for our patients? And also, another key kind of gap is really around at the perioperative period. The physicians and anesthesia providers are, I think, really overwhelmed with the amount of information that we're currently having to manage, and these data streams are actually going to increase over time. And how can we then take that information, have it integrated, and actually apply it and customize it for really precision level care for our patients? To help address these gaps, augmented intelligence is really about using AI tools and helping to really enhance human capabilities. And I would suggest again looking to kind of very much to the future, ways that augmented intelligence can help with addressing these gaps is enhanced predictive analytics at the individual level, real-time population level management, and reduced cognitive load for our healthcare providers. Three, I think, points to set the stage for this presentation, which is really in the first graph to your left there, you're seeing a kind of ongoing data from Health and Human Services about the ongoing trends in drug overdose death. What you can see clearly here, and again, this is data that's, I think, known to everyone, which is that the opioid epidemic is continuing unabated, with significant increases in drug overdoses related to synthetic opioids, psychostimulants, cocaine, prescription opioids still, and heroin. At the same time, in this study from University of Michigan, we're seeing opioid prescribing by surgeons. And again, this is a retrospective study that looked at prescribing by surgeons. You can see a decrease in the number of prescriptions. But what's interesting and what they found was that the number of pills still continues to stay relatively high and potentially disproportionate to what patients need. And in terms of the third point, I think certainly this is that there's a differential overdose risk after hospital discharge. This is a study from our team where we looked at doing a national VA study of about 64,000 patients. And what we found was that the incidence of overdose was about 11-fold greater within the first 30 days after hospital discharge than in the rest of the year after hospital discharge. So in really indicating that we have a period in which we can intervene, and how can augmented intelligence really play a role in that. What are some traditional ways that we've been managing opioid risk? There are four really: prescription drug monitoring programs, opioid contracts, patient education, and the use of multimodal analgesia. PDMPs are really widely used. And they've started to make a difference, and data show that they have about an 8 to 12% decrease in risky, so-called risky prescriptions. But there's some challenges in using PDMPs, and the fact that data sharing between states is often incomplete, that data can be, that they're not being accessed as the way that they need to be. Opioid contracts, they are very useful in helping manage opioid prescription use by patients, but that can be perceived as being potentially coercive and are sometimes lead to challenging discussions about how patients should be managing their opioid medications. Obviously, patient education is an important and ongoing role for how best to manage opioids and potentially ways to talk about opioid use, wasting, and really also about the role for disposal within the community. And finally, the use of multimodal analgesia. Multimodal analgesia has been shown to really is just, again, non-opioid analgesics has been shown to decrease opioid use anywhere from up to about 30% of, whether it's in the hospital or out of the hospital potentially. So it's an ongoing important tool in our management strategies. But what are some of these gaps? And I would suggest there are like really two gaps, two sets of gaps, rather, as we mentioned: comprehensive risk assessment tools that really take all of those information data streams that we have available now, that really look at the preoperative period and look at patients' history of substance use, their past social history, where the community that they live in, their all of the kind of really biological data streams such as genomics and metabolomic data, and really their combined picture, and really say, can we actually put this together to provide a comprehensive risk assessment for our particular patient as opposed to a population level average assessment. And another, certainly, I think, gap would be around perioperative information overload. I think as healthcare providers in general, we're subjected to so much data that the act of trying to kind of take and integrate all this information and apply it to the patient that we have, particularly around surgery, can often be challenging and leads to, I think, difficulties in really customizing to the particular patient's needs at hand. With that, I think there is that, certainly as we look to potentially AI tools, I think it's important to kind of think about Moravec's paradox. And Hans Moravec is a computer scientist at Carnegie Mellon University. And he noted a while ago that machines and humans really have opposite strengths and weaknesses. Computers are really very strong at reasoning, at handling large volumes of data and doing it very quickly. Humans, on the other hand, are adept at obviously it's sensory motor kind of needs of being able to pick a particular screw out of a set of tools here, and really being able to obviously be related, provide that kind of empathetic care to patients that patients need. So really, an opposite set of strengths and weaknesses, and things that can be kind of, as we look to incorporate AI tools, how can we then take advantages of these strengths and weaknesses to provide certainly an approach that incorporates both. And this is certainly, I think a statement from the AMA, and they kind of really came up with this idea of augmented intelligence. This is how I think many clinicians view the development and use of AI tools, which is a conceptualization of AI that focuses on AI's assistive role, emphasizing its design to enhance human intelligence rather than replace it. And I think we all want, AI to kind of really assist us in taking better care of our patients. And I think part of this is ensuring that humans are in the decision loop as opposed to being replaced. With that said, this approach has started and really kind of, and it kind of started especially with the COVID pandemic. But I think, and I saw this headline, but I think it goes to the point that, during the COVID pandemic, hundreds of AI tools were built to catch COVID, but really none of them helped. And I think there were severe limitations. And I think one of the key limitations were that clinicians were not involved in the development. There was a lack of really good external data as these tools were being quickly deployed and trying to be used. And a real lack of understanding of the kind of healthcare needs and environment. So with that said, I think some substantial progress has been made, which is that in many ways, augmented intelligence is already here. We have already, the use of various what are called large language models or generative AI, such as ChatGPT, Gemini, Claude, or Perplexity. Just as a quick show of hands, how many have used something like ChatGPT over the past year? So quite a few people. So I think, and again, I think the reason why I mentioned this is because I think the ability to have conversations and have tools that you can interact with is really the model of, I think, this idea of augmented intelligence. And so how can we start to apply that to the other spheres, and particularly to managing opioid risks? So I think there are really, three potential ways. And the first way is, I think, really better and comprehensive predictive analytics at the individual level. This is an example, and this is a paper from Journal of Biomedical Informatics. They used Cerner's entire EHR to look and predict patients who were at opioid use risk. And what they did is they used a form of what's called it's a deep learning model. They used what was called a type of recurrent neural network called long short-term memory modeling, which is looking at patterns of outcomes over time, looking at really essentially a time series, as you can see. And what they found was that, and if you look on the right side, was that, and they tried a variety of models, and with the type of long short-term memory model, they found like an area under the curve around 0.89. But the larger point is that these models are starting to become developed, and this is just using one data stream. And I think as over time comes, additional data streams will start to become available and be incorporated into these models, and these models will become even better. Another kind of really, I think, potential use of augmented intelligence is the use of population management of opioid risk in real time. This is from the VA. It's a tool. It's called STORM. Which stands for Stratification Tool for Opioid Risk Management. It's a web-based tool that combines, and it may be a little bit harder to see it, but it's a dashboard that's available for all patients. This is a model that is run for millions of patients every night to update their incremental risk for various adverse opioid outcomes. And it looks at their current medication regimen, various past medical history items, various interventions that have been done to project a probability for an overdose within the next year or various adverse outcomes. But I think what it serves to illustrate is that these tools, and as you can see, some of the other tools that were kind of illustrated, that were mentioned here, is that these tools will allow us to manage populations in real time, and they will only get better. And finally, I think that there's an opportunity for augmented intelligence to reduce cognitive load for providers. And that they can really help in terms of patient management with real-time assistance and monitoring. If you take a scenario, say a patient who's scheduled for, say, something like a laparoscopic cholecystectomy, who's critically ill with a history of sepsis, and has a history of chronic opioid use. And again, this is kind of looking more towards the future. This isn't there now, but you can imagine a situation where the anesthesia provider decides to use a large language model assisted management system that's to help manage the patient during the procedure. At the start of the procedure, the patient's preoperative vital signs and data are all inputted, and the large language model then generates a potential plan that one can be to help really help throughout the induction phase and throughout the postoperative phase. During that induction, the LLM decides and helps, not decides, but really suggests, and I would say that's probably a better way to say it, suggests an induction regimen, but that helps also kind of modify it on the fly with the various, certain infusions that have been shown to improve various outcomes. During the maintenance phase, the LLM can really suggest various interventions, various additional medications to help improve and decrease the risks of associated with opioids. And throughout the either in the recovery room or TICU, the patient suggests various, again, medications, either they're multimodal combinations that have been shown to work in this patient population to really improve those long-term outcomes. So with that, I think in a quick summary, certainly, that augmented intelligence is really a way of thinking about AI tools to help with clinician decision-making. It can help manage some of the gaps related to opioid risk management around comprehensive risk assessment, and also around perioperative kind of really information overload by enhancing predictive analytics at the individual level, at the population level, and certainly I think potentially reducing cognitive load while we take care of our patients. So thank you for your attention and your time.
We'd like to invite folks to offer some questions to our panel. Go ahead.
Two questions about opioid diversion. The first is, has there been any thought put into, from the clinician perspective, about incentives or unintended consequences? Because what I see in our practice oftentimes is all this extra scrutiny and hassle either incentivize people to not use opioids, which may or may not be appropriate for the patient, to empty the syringe in the patient, which may or may not be. Thank you, which may or may not be appropriate. Or, our medication security specialist is so intolerant of discrepancies that we can't be honest about what we're wasting because of dead space and various, things. And so we're incentivized just to make everything match the chart. Otherwise, there's a bunch of emails and hassle. So I didn't know if there's been any thought about what that, this environment of surveillance and extra scrutiny and hassle creates clinically. And then my second question is just about the effectiveness of a lot of this. The overall sentiment is there's a lot of theater. We joke in the OR that you never leave an instrument in the patient when the count is wrong. You only do it when the count is correct. And so, we worry about after all this, I asked our security specialist, you send us thousands of emails a year and create a bunch of extra work. Have you ever caught anybody with any of this? And the answer is usually no. And so you already mentioned a false negative where, if someone's really motivated, it's not going to necessarily catch them. I also worry about false positives. Do we make people pee in cups unnecessarily and all the anxiety and that generates? So do we have any evidence about either unintended consequences or efficacy of all this added scrutiny?
Yeah, I wish I had evidence that it worked or did not work, because then we could stop doing it. Yeah, it's the hardest thing about all this, right? Is that you can, just by having the nature say, hey, we're going to look at the exact amount that you wasted, but I know that 10 mics is in your pocket, but it's easier for me to just say, oh, let's just waste 60 together. I know that I can see the stain right there. I know that's where the other 10 mics is. So yeah, it's the egg, the chicken and the egg. Which one comes first? Which one comes second? Now, we have caught people, and we have had some positive outcomes. And by caught, I don't mean that as a negative thing. I mean is that we have sent people to treatment, to rehabilitation, and we have some people that now no longer practice anesthesia, and some people that were able to come back into the practice of anesthesia with just some more surveillance. So I want to be clear that there has been some positive outcomes within our institution. The amount of work that was there when it was a more manual process was more, and it was a lot more time consuming for what I talked to you before about Lisa Sandy and the guy from pharmacy. But now that things are a little bit more automated and just more of the spying happens on the back end, that seems to be a little bit less time consuming. And also, pharmacy takes the shoulders away from our anesthesia chair people. So the pharmacist is the one calling the anesthesia, like their directors or their direct supervisors, and saying, hey, maybe this is a work thing, but we're going to go ahead and get this person drug tested or not drug tested. Honestly, after the death a month ago, things have been we've been hyper vigilant. Like someone wasn't feeling well the other day and she almost passed out. I made them drug test her. Like we have been really extra, and she obviously just had a cold or something like that. So, it's like those things, we've been a little bit extra on that. But that's just the nuance of this is the current period that we're in. So I agree with you. I do not know of studies that have shown that just by having these monitoring and surveillance programs that you are causing people to use less opiates. Because we learned yesterday, I didn't learn yesterday because I wasn't here yet, but I've heard that you guys learned yesterday that giving opiates and reducing pain in the operating room actually decreases the amount of opiates that they're using long term, right? That was like one of the talks yesterday. And so, we still have to treat pain, and we know that the outcomes are still better, and that's what we need to be focusing on.
Thank you. Yeah.
Hi, Arnie Abcejo, Mayo Clinic, Rochester. I think this is a question I think this is the right group for Sesh, Dom with an epic background as well. You shouldn't have name dropped that.
I know, I regret it.
Yeah, that's your fault. Honestly, how close are we to leveraging augmented intelligence, AI, generative language modeling within our documentation software like Epic? Like just what's our progress report on that? Because I know Epic's working on it. I know people are working on it in silos, but how honestly close are we in the anesthesia arena for clinical decision making?
Sure. Yeah. Thanks for that question. I can tell you that our residents are using various versions of like either ChatGPT or whatever on their phone in the OR now. So I think it's being used. I think attendings are using it. So I think it's already here. Whether it's becoming an official part of the kind of the EHR, I think that's still emerging. One thing certainly here at Stanford is that because ChatGPT is a general purpose large language model. It's not a medically, it wasn't really trained on, and wasn't designed to be a medical large language model. Stanford is developing its own internal version that's HIPAA compliant, as I think many other institutions are starting to do. For large language models that work on their own corpus of data for their own patient population. I think it's just a matter of time before that then gets incorporated into the Epic instantiation at one's facility. So I do think it's coming. I don't think we're there yet, but I do think people are already starting to use it unofficially outside of the official EHR.
So I just got back. So Epic has two large meetings every year. One's called the user group meeting, and one is called the experts group meeting. So the user group meeting is a meeting. It's like 30,000 people. It's humongous, and everyone goes up there. And their theme, it was 2 weeks ago, was all about AI, and there wasn't a single talk that didn't have to do with Epic incorporating AI for clinical decision support. So that being said, Epic is stubborn. And one thing they're stubborn about is that they want to make sure that they are developing all of these things in-house. They have propriety. So they are actually partnering with some of the Microsoft chat team. I'm not sure which one, it doesn't matter. But they are partnering with them to help them develop these models quicker. Okay? So I do think that we will see, Arnie, in you and I's career, that we will see the ability that we will have valid clinical decision support from augmented intelligence or artificial intelligence within Epic in the next 5 to 10 years that we say is actually reliable and useful. Now, I'm not, that's talking from Dom Carollo, like I'm not like Epic corporate shill here. I just want to let you know that they are constantly talking about it, and that's honestly all they really talk. What's about from an anesthesia perspective? I mean, I would like a search of every single chart for this patient in front of me across the entire state of Louisiana or across the entire country. But the hard part is that all the data is entered a little bit different because Epic is customizable for Stanford versus Mayo versus Ochsner. And so how does Epic incorporate that and still get the data together? And on another side, really quick, is that I don't know if you do use Epic. They do have Cosmos, which is their research tool. And that does go across, it's de-identified data, and it does go across systems and across networks to be able to look for research on, it's like, I don't know, 2 billion data entries or something like that. So they do have that.
Yeah, and to add to that, Epic is using Copilot. And so we've been running Copilot in the pharmacy for the last year. And we've determined that we have pharmacy verification and fix. What we do is workflow. So pharmacy techs prepare a dose, take a picture of the dose, and we have pharmacists verify the picture. And the goal of that is use barcoding to make sure the technicians are getting the right product. But then what we started doing is we put a Copilot on top of that and started running machine learning to see whether the pharmacists were actually verifying the correct dose that's drawn up, because we don't use gravimetrics. As actually looking at the syringe and comparing what the dose was to what was pulled up, there's a 3% error rate. And so we're learning a lot from machine learning, learning a lot from Copilot that basically gives us data to say how to approach errors in general. And you might say 3%. We're running 6,000 doses a day. So 3% error rate is extremely high.
Well, great. I'd like to thank our panel for a great session, and we'll draw this one to a close.